Hello everyone, and thank you for joining us today. My name is Mukesh Jain. I'm the Chief Academic Officer for University Hospitals, and it's a real pleasure for me to be here today to interview Dr. Cliff Megerian, physician scientist, an internationally recognized ENT surgeon, and the newly appointed CEO of University Hospitals.
Thank you. It's good to be here with you, Mukesh. Wonderful to have a chance to talk to you and certainly hopefully reach out to some of our alumni from UH.
Well, thanks very much for taking time,
Sure.
Cliff. One can only imagine what your schedule is like as you take over the helms of a very large health system.
Yeah, these are the important things, though. This time that's spent to improve our ability to attract and retain the best trainees and also to let our alumni know really what we're doing, which is arguably the best we've been in a long time.
Well, we would like to have a conversation, and this is an opportunity for the community, our alumni, to learn a little bit more about you. And so perhaps if you could start by telling us a little bit about yourself, where you grew up, and what made you want to become a physician and a surgeon ultimately.
Sure. So my parents were immigrants. We were first-generation Americans. My brother and my parents moved for educational purposes to the United States and settled in Detroit. So I was born in Detroit. Grew up always with a hard work ethic based on typical first-generation American kids. And I really got inspired, interestingly, when I was very, very little, watching at the time, was the TV coverage of Christian Barnard as he completed the first human heart transplant.
Yeah.
And actually they showed some images. I don't know if it was from the real surgery or if it was some of the simian surgery before, but I was absolutely drawn to the idea of being able to correct a problem with your own hands. And I was drawn to the notion of being a surgeon at a fairly young age. And so that's how I got interested in medicine.
And can you tell us a little bit about your medical training, and in particular, what brought you to UH for some of your training, and what were some of the highlights and your mentors during your training experience at university hospitals?
Back in the day, there were not as many ENT programs as there are today. I was, I think, beginning my senior year of medical school at University of Michigan, and they had a very strong ENT program, and I knew I wanted to go into ENT. I just loved the concept of the anatomy and the intricacy around working in the head and neck, and particularly the nuances around the inner ear and the skull base, and really that tiger country. I thought this would be perfect for me. So I applied to ENT programs all over the United States, but I was, being a first son, I wanted to stay relatively close to home with my parents, near my parents. So I applied in the Midwest mainly. And when I came to UH to interview, the program had only gotten started formally literally 2 years before, in 1985. And they had a leader who was larger than life. His name was Dr. Anthony Miniglia. In fact, he passed, and he left me his surgical loops, which are here.
Oh,
he was my boss's. These were my boss's surgical loops. But when I interviewed, this guy was literally larger than life, who accomplished so many things on so many different fronts. He was a leader in medical societies. He was a virtuoso surgeon who can do things and always innovate. And I just was drawn to the notion of training under this person. I felt he would be the perfect leader to constantly inspire me, because I wanted to be inspired. And he had a relatively new department, but a lot of resources. And he hired some really great people. And so I ranked it very, very highly, and I was fortunate to match here. And it was during that time that I realized how much incredible horsepower intellectually existed at university hospitals, and the history of many, many things being developed here for the first time. And we saw And I saw that with the people I met. I got to meet and learn a little bit from Fred Robbins, who is a Nobel laureate, who was a past dean. I learned from Oscar Ratnoff, who helped really determine the final piece and part of the clotting cycle with Hageman's factor. Yeah. And the list of luminaries that were just in the cafeteria, I was inspired and continue to be inspired to do something above and beyond, and there's nothing wrong with this, but above and beyond, I really wanted to have a role in being a leader in my field, whatever field that is, but also making as big as a difference I can. And I was inspired during my training, and I really feel that UH set me up to apply for a fellowship in what's called neuro-otology. And it was a fairly new fellowship, but it was a 2-year fellowship, which involves working with neurosurgeons on both sides of the dura. And I didn't even think I had a chance, but apparently they felt at Harvard that the research that I had done here as a resident was meritorious enough, and I had that I should be considered, and then I was offered the position. There were no matches. Now it's a match. And there were no matches. 2 days after our interview, they offered me the job. So here, I'd never been to Boston before, but I think UH and the curiosity, the ability to build research into your normal clinical lifestyle, the ability to get collaborators and work with collaborators, maybe in a way that there's not always a quid pro quo, but just by the betterment of science, is something I learned here at University Hospitals. And that then took me to the next phase, which was my fellowship in Boston at Mass Sinai Infirmary and Mass General.
Well, that's terrific. And so that had to be an incredibly rich experience at Mass Sinai. And any thoughts about or memories about that experience? And then you came back.
Right. You know, the thing I learned, I think, which is wonderful at Mass Sinai, was you were surrounded by basically the people who were writing all the books in your field. And so I was with Dr. Montgomery, Dr. Nadal, Dr. Shuknik. Those names may not mean anything to a non-otolaryngologist. But what I learned from them is it is completely possible, if you do it right, to have a rich clinical practice. But also, if you do it right and you have the right collaborators, to make meaningful, if you will, progress and meaningful contributions in the research world. And you just have to learn how to manage your time. So one of the things I learned was how to manage my time with regards to clinical work and then research. But the other thing I found, because I was surrounded by people who were also physicians who became leaders of the hospitals, Jerry Austin at Mass General, Bill Lavelle, my boss later on, who ran Blue Cross and Blue Shield and the Mass Med Society. I started seeing leaders who were making a difference in either the organizations that they were a part of, the hospitals, or in the community, in the greater world. And at the outside looking in, I thought that's impossible.
Yeah.
But I realized it is not impossible if you manage your time, you develop meaningful relationships with people, and you understand what it is that the community wants. And so I never really dreamed at that time that I'd be CEO. What I really wanted to do at that point was get started with my career and perhaps one day be considered for a chairmanship somewhere. So then you ask, how did I get here? Is my wife, who I met here in Cleveland. She was a physician. I was a third-year surgical resident, ENT resident, and she was an intern in medicine before she did her residency in PM&R. And so, of course, we were there together, and we started having our children. And by 2002, we had 3 kids, all under 4, most of them in diapers most of the day. And my wife said, we got to move back to Cleveland, because my mom's there, our family's there, my parents are in Detroit. So what I missed about Cleveland was I missed the Midwest nice. Mm-hmm. I mean, Boston's nice, but it's not Midwest nice, right? Yes. People open doors for you. They don't mind waiting. People are very, very forgiving. And I miss that, but I also miss the collaborative nature. I'm not saying we didn't collaborate perfectly or well in the Boston environment, but there's something about how in Cleveland, even when I was a resident, people were just eager to help you, whether it be do an assay for you, help you use a confocal microscope, have you come in and watch a surgery in an allied field. I didn't get that all the time in Boston. So I wanted to come back because I thought it's a better environment for me to do what I want to do, which is perhaps not only be a clinical leader, but an administrative leader, but also for our family, because we had family here. So I came back in 2002, and my job when I was hired was to grow. Again, the department was still small at the time in ENT at UH, but was to grow the ear surgery program, specifically cochlear implants, skull-based surgery, and the like. And it was pretty nascent when I got here in that area.
So I'd like to pick up on a couple of comments you've made. One is the cochlear surgery, your interest in research, and you came back, you were involved in patient care, you pioneered cochlear implants in children, you were funded through the National Institutes of Health for your research. You are a true blue physician scientist. And what does that mean to you as you look back at your career? What did it mean then? How do you look at it today?
Well, I didn't get to the sphere that you're at, Mukesh, in terms of being a physician scientist. I'm not in the National Academy of Medicine, and I don't have the reams of R01 grants you did. But I learned very quickly what it was like to try to be a physician, have protected time to do preliminary research, apply and then reapply, and then maybe reapply again for grants at the NIH level, and then get those grants and run them. What I really learned is that, number one, why did it help me? It helped me a lot because I later after I was chair, I became president of the physician organization here at University Hospitals for 6 years. And I oversaw the employment, the hiring, the maintenance, the care and feeding, really, of all of these physicians. And I had firsthand knowledge of how hard it is to be having a productive research career unless the leadership understands the additional time and effort and work. So when someone says I'm 0.2 research, 1 day a week research, I realize that you need more than that. So I tried my hardest during my presidency to create as much of an opportunity to have extra resources delivered to clinician scientists so they would be successful. So one of the major benefits of me having a research career and clinical scientist part of my life was when I got into a leadership role, being cognizant of what it takes. It's more than just getting a grant. It's the infrastructure. It's the core laboratories. It's the ability to have other folks who are researchers and have so-called critical mass of researchers so you could share ideas and share collaborations. So I would say possibly the biggest benefit of me being funded by the NIH was not necessarily the research we produce. I think we produce some very fascinating research. That's my personal opinion, but probably no one else cares. What really matters to me was how it got me ready to be a leader, now a CEO, who understands what is really involved. Not just check the box, but to create the proper environment for research to thrive in an academic environment.
Yeah. Well, that's great, and it's vitally important, as you know, because large academic health systems all have a tripartite mission. Ours is to heal, to teach, to discover, and so having a leader who understands all three components is vitally important. Can you tell us, as you now take over the helms and look ahead, to teach, to discover components, how do you see UH evolving in those two spheres?
Well, I think to heal, to teach, discover, and what you're asking about is to teach and discover.
To discover those, right.
So let's just talk about that a little bit. We have at any given time 1,100 residents and fellows in this organization. We've gone through various, if you will, iterations of the amount of attention that is turned on making sure we inculcate research, that means discovering, into our curriculum. It is my personal feeling that we will be even more successful if we can enhance the amount of research exposure and research training that we build into the mandatory curriculums of our residents. I'll give I never would have qualified for a fellowship at Harvard if it wasn't for Dr. Maniglia, who was the chairman, who gave all of us a mandatory 4 or 6 month free from clinical activity research block. And I was very fortunate to do that research block with noted scientists, NIH funded. And I got the idea of what it would take for me, if I so choose, to have an academic career. Not everyone has to have an academic career, but let me just give you a few statistics right now, what is happening. When I was a resident here, graduating in '93, I was the second in the history of the department to ever do a fellowship. Most went into private practice. That's fine. What we're seeing now, whether it's orthopedics, ophthalmology, ENT, all of medicine, almost 80 to 85% of folks graduating our residencies are now doing fellowships. And what you know is that and then once you do the fellowship, you know whether you're a rheumatologist who's interested in lupus, or you're a neurotologist like me who's interested in doing high-end skull-base surgery, the best place you're going to be able to do that clinical work is at an academic medical center. So then how are you most fit and prepared for a job in an academic medical center is you don't play research catch-up during your fellowship. You've got it as a resident. And guess what? What we know is that our residents who get exposure and do research, maybe are in a paper or two, they have a better chance of getting the better fellowship. And then, so what should be our solution in our education, our teaching and discovery? We should begin the discovery at the nascent part of their residency program, because statistics shows most of these grads are going to want a fellowship. They want the best fellowship. Therefore, they need the research to make them competitive. And once they finish their fellowship, they're going to want an academic job at a Baylor or a UH or a Cleveland Clinic or a Mass General. What's going to set them apart? It's going to be the ability to do that tripartite mission. So I think that we need to be able to be as good as we can to give our graduates the best chance to succeed in what it appears that they want right now.
Right. Through your career, you mentioned this earlier, as you were going through the early part of your career and you thought about coming back, and you even had in your mind leadership role, chairman. But you went far beyond that, became president of UH Physician Network and now CEO of the health system. And you've talked a little bit about how you were inspired by seeing other leaders and how they could either lead organizations or lead health-related entities. What career advice would you give to young faculty who want to be leaders in the field?
That's a really good question. I get asked that a lot, and I'll start out with saying the following: at every stage of your career, my advice would be to find somebody that you look up to, or better yet, you find someone that other people look up to in your organization or outside your organization. It doesn't have to be in your organization. At least 1 to 2 to 3 people who they agree to mentor you, to guide you. These should be people who have developed a substantial leadership position. Leadership typically is given not necessarily to the person who has the most technical knowledge in the field around that leadership arena. It's given to the person who demonstrates the best judgment and the best temperament. And a lot of that can be honed. So it's not born. Right. It can be honed. I've developed tremendously in the last 20 years through my mentors, through self-teaching, through courses, through business training, and all of the like. So the first thing I would say is find yourself some mentors who you could talk to, and you be completely honest, and let them be completely honest with you as to what are your strengths, what are your weaknesses, as it relates to something you think you may want to do. And then it's going to take work. And then what is the work? The work is reading and self-education. So you find books about leaders and you digest them. So I have been fascinated with books and leaders, and on my bedstand every night is at least 2 books I'm reading about either a great leader or a failed leader. And many of those lessons can be translated into the world that anybody lives in. So I think those are 2 very, very important things. And then it would be very helpful in the organization that you're at, that you ultimately find a patron. In other words, someone who believes in you, believes that you have the right stuff to maybe get to the next level. So when I was a junior faculty here in 2002, there were a number of people who, my old boss at Harvard was a very important mentor to me. Dr. Maniglia, who had since retired, was a very important mentor to me. And then I had actually Tom Zenti, who was a CEO at the time, took a interest in my development and helped me a great deal. And I think that is important to find these kind of patrons.
Yeah, that's great. So role models, if you will, and a patron within the organization. And then I really like, I think something I will do myself, which is learning, from your reading, learning about great leaders and leaders that experiences that were not as successful, because there's a lot to learn from that.
Two things that I would point out that I think is important to know. One is, which I've learned, everything you do, whether it be a project, whether it be a new collaboration, whether it be a new relationship, the wrong way to do it is expect that individual relationship is going to somehow pay you dividends.
Right.
In other words, there's a quid pro quo.
Yeah.
The smart way to do things is have relationships that are stripped of a transactional fee, that you have the relationship because there's a genuine interest that you have in just learning about this person, how they fared, and learning from them. If you can do that and be honest and brutally honest with yourself, that your relationship, your circle of contacts is growing because you want to genuinely learn from them, you don't expect anything from them, then you will be successful. The second thing I think is very important is that at some point you need to have a analysis of your personality, of your strengths and your weaknesses. And the good news is that UH, as leaders rise through it, we hire outside companies. One of them is called Telos. I was fortunate that when I was in the Leadership Academy, number 12, 13 years ago, they assigned a coach to me. That was just part of the curriculum for 18 months. So you go through all the normal testing, you find out your strengths, you find out your weaknesses. And then they do a 360 analysis of all the people who work around you.
Right.
And you find out it's not all perfect.
Yeah.
It's not all perfect. Cliff can improve. Here are the areas. Cliff is good at these things, needs to improve in these. And you then diligently work on the notion we call intentional change. It's really based on the work of Professor Boyatzis, actually here at Case, and emotional intelligence, that these things about how you show up, if you understand where your weaknesses are and you acknowledge them, that you can then intentionally change your behavior and how you show up. Yeah. And there's subtle things you never thought about before. That is important. I think every person that we have promoted to the, certainly that lives in the C-suite, which is my direct reports, have gone through that. And I would be shocked if the Fortune 500 CEOs would not have said that all the reports have gone through that.
Well, thank you. That's a great set of comments from all of us to learn from. I'm going to shift gears and ask you about our community. Cleveland's home to one of the richest biomedical enterprises, great hospitals, great university. And are there plans or thoughts about building collaborations? Obviously, university hospitals and Case Western have had a relationship that dates back to 1895, but the city could do so much more. And your thoughts about collaborations citywide?
I think you hit the nail on the head. I think, you being a Harvard person, me having spent 9 years there, although there's some competition, one thing that the Harvard environment has eschewed is the notion of all the Harvard hospitals at the very least, which there's many of them, Beth Israel, Brigham, Dana-Farber, Mass General, Mass Eye and Ear, Joslin Diabetes, is they work together in many, many ways. And I think that this community is now just starting the realization that we will be more successful if we collaborate. Yeah. So we have some short-term wins, which has started, I think, a dozen years ago when Cleveland Clinic and UH decided to work together for a citywide case comprehensive cancer center. Mm-hmm. And that is starting to show dividends. We got our feet wet and our beaks wet on the notion of working together and not necessarily worrying about who gets credit for every penny, nickel, dime, and Deutschmark. I mean, we figured we got there. So I think we use that momentum to go and work outside that with Case Western, Cleveland State, CWRU, UH, the clinic, Metro, to come together this year in a joint application for nearly $500 million grant from the state through Jobs Ohio, whereby we essentially said we will work together in jobs creation around the biomedical health arena. Education, job creation, drug discovery, device discovery. Each of us will have certain niches, and we will all work together. So as you know, that was just announced just a few short weeks ago. But I think that came on the heels of us getting comfortable a dozen years ago or more by working together collaboratively. Look, each one of those organizations has a strength. Mm-hmm. And each one of us admits that the other may do things a little bit different or better than we do in certain arenas. I think it was a stroke of genius that we, not necessarily by us, it was the state who said, we think you guys can work together.
Right.
And they came in, and Governor DeWine came in, and J.P. Nassif, who runs Jobs Ohio, and now we have to go to the next level and show that we could collaborate. The good news is someone's watching over us. I think the world is our oyster here in Cleveland. You're right. Mm-hmm. The overall concentration of individual talents and resources, I think, are rivaled only by Boston. Mm-hmm. And we have an environment which is collegial. Yep. We have lack of traffic. We have affordable living. We have tons of water, fresh water, not salt water. And I think all those things will make, in my opinion, Cleveland a growing concern as it relates to a hub of technology.
And I guess I'm close to the end of my questions, Cliff. I just want to give you an opportunity. I know you're very proud of University Hospitals, its history. You're going to be leading us into the future. What excites you the most, and what are keys that you think will be critical to our success?
I think what excites me the most about UH, first of all, is the gumption and moxie that this organization has. And I go back to World War I, and before World War I, I've told this story many times, but there's a reason for it. Before World War I, we were in it in 1917. We were essentially an observer, and Woodrow Wilson reached out to three hospitals in the nation: University Hospitals, Johns Hopkins, and Harvard, mainly the Brigham, because Harvey Cushing was the chief surgeon there. And he said, I need all three of you to get over to France and build a hospital unit, because our allies were not into the war yet, but we need to help them in medical. The first hospital to collect all the doctors, all the nurses, and there's a plaque in Lakeside which has all their names, that sailed in 1917 and got there in France was UH. It was called the Lakeside Unit. And at the same time, a few months later, the Spanish flu hit. Mm-hmm. Millions upon millions of Americans died. We're certainly struggling with a horrible problem here with COVID, but it was logarithmically more devastating. Our contracted hospital, half nurses, half the doctors, because everyone was in France in World War I, took care of this community. Back then, the UH was pretty much on its own. I mean, the Cleveland Clinic hadn't been born yet. Remember, it was born out of UH, and they did it. They won the Red Cross Award for one of the best hospitals in the nation as it related. So I think in our DNA is an incredible ability to rise up to challenge. And we've seen that during COVID. This hospital was the first to get testing done. This hospital's people volunteered their time. This hospital took voluntary changes in certain aspects of their compensation to keep the hospital going. This hospital was the only one to develop remdesivir, the therapeutic, and Pfizer's vaccine, and then AstraZeneca's vaccine, and now an oral therapeutic under Grace McComsey as of yesterday, and the Massimo device. And we're one of the most efficient as it relates to vaccine delivery. If we could bottle, what I'm excited about is there is in this organization a spirit of we can do anything. We can do anything if we put our minds to it. And I want to bottle that and now have that push the organization for the next 10 years in doing the things that we know we need. And those things, as you know, we need better access to health care, not just in the communities, but in the inner cities where people don't have access, either by transportation or no resource. We need to deliver that for them. We need to improve the value that's delivered in health care, so we know we're having the best quality at the lowest cost. Because as time goes on, a bigger part of the cost is borne by the patient, as you know,
Right.
from deductibles. We need to be the leaders in science and translational research and drug discovery, which we are with the Harrington Discovery Institute, and you saw during COVID. And we need to be the place that, as care becomes more and more, if you will, dispersed, some at home, some in the office, some in the hospital, we need to be the place that is perceived to be the highest compassion and highest touch interactions between human beings. Because we now know from research that the better a patient feels about the interaction, whether it be online or it be in person in your office or my office, I still see patients, the better they will adhere to your recommendations. They'll be more compliant. If they have a life-threatening problem, they'll have more hope.
Right.
If their interaction was one of trust and love. Okay?
Right.
So I believe those are our major tenets, and we need to build that in so it is hermetically sealed into the patient's interactions, and it becomes a brand.
Right.
And that's my goal.
That's good. Well, Cliff, thank you. That was an incredibly inspiring set of comments for us to conclude on.
Thank you.
I just want to thank you. We're just excited to have a physician leader who has a history and an understanding of the institution, its tripartite mission, and an aspirational vision for our future. So thank you.
Thank you, Mukesh. I'm going to learn from you too.
I'll try.
We all teach each other, right?
Yeah. Thanks very much.
Thank you.
Thank you
Mukesh.
for taking the
Sure.
time.
Thank you.